Hello and good evening, everyone. A very warm welcome to all of you on behalf of the South African Medical Research Council's Bioethics Advisory Panel. So I'm Professor Ames Dhai, Chair of the Bioethics Advisory Panel, and we have gathered here this evening because many are grappling with the complexities associated with COVID-19 vaccine mandates and certificates. And currently, several workplaces, institutions of higher learning, and various recreational facilities have moved forward to implement the requirement of proof of vaccination or a recent negative SARS-CoV-2 test prior to entry to their premises. However, concern has been raised that this could be a violation of human rights, amongst other things. So what we've done is we have brought together a panel of distinguished experts who, with the use of science, law, and ethics, will this evening assist us navigate these dilemmas and shed some light on why COVID-19 vaccines are a necessary step in the process of realizing the total health of the nation. So with us tonight, we have Professors Glenda Gray, Tracey, Naledi, and Halton, Cheadle. Professor Glenda Gray is an NRF A1 rated scientist, CEO and president of the South African Medical Research Council. She's a qualified pediatrician and co-founder of the internationally recognized perinatal HIV research unit in Soweto. She has an outstanding profile locally and internationally. I'm not going to go through this. Safe to say that as the COVID-19 pandemic developed, she was amongst the first to lead the public discourse on the issue. And she continues to do so. And she moved quickly to establish COVID-19 vaccine trials in South Africa. She served as protocol co-chair of the multinational Ensemble study investigating the single-dose J&J vaccine as an emergency response intervention. I think what she is currently best known for during this pandemic is that when South Africa's national vaccine rollout faltered, her international stature enabled her to negotiate a donation of 500,000 doses of the J&J vaccine before any emergency use authorization was available, and conduct a phase 3B open label study in healthcare workers. And we all know this as the Sisonke study. And she has once again come to the rescue of healthcare workers, where she's managed to again get vaccines for us. So boosters are available to us before the fourth wave hits. Professor Tracey Naledi is a public health medicine specialist who has held technical and management positions in government and NGO sectors in South Africa and Botswana. She's the Deputy Dean Health Services at the UCT Faculty of Health Sciences. Her public health work is focused on translation of research into policy and practice, and where she addresses health inequity and strengthening systems for health. Tracey has held multiple governance positions and is the founding chairperson of Tekano, Atlantic Fellows for Health Equity in South Africa, and she's the honorary secretary of the Council for Public Health Medicine of the Colleges of Medicine in South Africa. She's a Discovery Foundation Fellow and the Desmond and Leah Tutu Legacy Foundation Fellow. Third, last but not least, we also have Professor Halton Cheadle, who's an attorney with 36 years experience. He was a founding partner of the law firm Cheadle, Thompson and Haysom, and in 2014 joined Bradley Conradi to establish the firm Bradley Conradi Halton Cheadle. He was appointed special advisor to the first post-apartheid Minister of Labour, Tito Mboweni, and in that capacity was appointed as the convener of the drafting team that drafted the 1995 Labour Relations Act. He's also been involved in the drafting, and he's also participated in several related acts that followed. He is currently Professor Emeritus at the University of Cape Town. His academic career began in 1978 when he joined the Center for Applied Legal Studies at Wits University. Of note, he is the first South African to sit on the International Labour Organization Committee of Experts on the application of conventions and recommendations, and that's based in Geneva. So our format this evening is conversational, and I will start off by posing some questions to our panelists. But before I do that, just some housekeeping. Please pose your Q&A, your comments or questions in the Q&A facility. I'm not going to be looking at the chat facility. So if you don't pose your comments in the Q&A, unfortunately, your questions, which might actually be really pertinent, may not be responded to. For those of you that have queried about CPD points, yes, there's one CPD point in ethics. And without further ado, let's move over to Glenda. So I know I said it's been going to be conversational, but Glenda will present some slides to set the scene. And Glenda, what I want to ask you to do is to briefly discuss your global experience on mandatory vaccinations. And this is specifically based on your interactions with policymakers internationally. And how is this justified? And what's the science behind all this? Glenda, over.
Thanks, Ames. Can you see my slides now?
Yes, we can.
Are you able to hear me? So thank you, Ames. I'm just going to set the scene with a few slides. But I think the most important thing for us to realize today is that only 4.2% of people in low-income countries have received at least one dose. So we are doing something wrong, and we need to address this. So although 7.34 billion doses have been given, and 28 million doses are administered each day, the countries like South Africa and Africa lag behind the developed world. If we have a look at countries who've had prior vaccine mandates, and this is vaccine mandates that were non-COVID, but were for childhood vaccination, etc., you can see that a lot of parts of the world has had vaccine mandates in the past. In some areas in Canada, children must be vaccinated to attend school. In certain parts of the Middle East, for example, Kuwaiti parents face jail time if they don't immunize their children. In Australia, anti-vax parents cannot receive child benefits. However, there are other examples where places like Sweden have achieved a 97% jab rate without a mandate. And so we do need to look at what are the issues that drive vaccine mandates, and what are the issues in society that allow certain countries like Sweden to get high rates of coverage without mandates. But certainly vaccine mandates aren't rare, and they're quite common at a global level and have been implemented even in South Africa for childhood vaccinations. There are many benefits of vaccines, and we can debate this later on. But the first and foremost is the individual health benefit, where by getting a vaccine, we reduce our risk of death, being hospitalized, and having severe COVID. There are also public health benefits. By vaccinating, we keep our hospitals open and allow them to function for other diseases. There are academic benefits. 40% of school academic days were lost at school last year, and we also lost many days at university. So by vaccinating teachers and lecturers and students, both at school and at university, we're able to retain and maintain the academic year that is so critical for the future of our country. And then there's also the economical benefits. By vaccinating workers in our country, we're able to keep people employed in their jobs and rolling out the economy. So vaccine mandates are pro-poor and they're pro-working class, because they keep our workers from dying and from having to be hospitalized, and they keep them in jobs. There's been lots of debate about vaccine mandates, and they've spurred many protests and resignations. But the evidence so far points to marginal workforce losses. And the evidence also suggests that mandates keep people safe and save lives. If we just look across the world, vaccination mandates seem to be boosting immunization rates. So that means that vaccine mandates do work. In France, the widely reported spending of 3,000 healthcare workers for backing a vaccine mandate only equaled 0.1% of all healthcare workers. And in fact, since that, France's overall vaccination rate has actually risen since this directive, and others like it, since others like it were announced. In Italy, people have largely accepted a requirement for workers to be vaccinated or get frequently tested. And in the US, all the plans plans to quit en masse in response to mandates have not materialized. And in fact, even with healthcare workers, vaccine mandate-related departures at US hospitals have really only ranged from 0.2% to no more than 4.7% of staff. So people are not voting with their feet when vaccine mandates are being implemented. If we look at change in turnover in US employers, and most people from this report see no change in turnover, and only 4% of 1,000 companies surveyed have reported significant increase of turnover due to vaccine mandates. So, in fact, vaccine mandates have not led to people resigning or not coming to work. But vaccination is a very important thing, and we need to understand the relationship of vaccination in the workplace and why we vaccinate against pandemics, and how we bring vaccinations in our response and recovery from this COVID pandemic, and see the impact of the mandates on economic, business, and ability to open up our economy. We have to vaccinate against a pandemic, and we need to make sure we address all the issues around vaccine hesitancy to ensure that we can restore our economy and reinstall our workforce. So I'm going to stop there. I just wanted to share this, just to paint the scene about the position around vaccine mandates at the MRC. Thanks.
Thank you. Thank you so much, Glenda, for setting the scene this way. I think we'll move on to Tracey now, because there's been much said about the institutions, tertiary institutions, and vaccine mandates and certificates out there. So Tracey, can you share your experience with us as an educator at a higher a tertiary institution, and can you inform us as to how these institutions are actually grappling with the situation and how they plan to move forward? Thanks. Over, Tracey.
Thank you so much, Ames. So in September of this year, the deans of the health sciences institutions and medical schools, the majority of them, actually came out with a statement, a public statement, where they basically recommended that there should be mandatory vaccination for health sciences students, for health workers. And you'll recall, as you touched on when you were introducing Glenda, that there was the Sisonke 1 trial that was focusing on health workers and health sciences students. That happened from around February, March of this year, and also recommended that that group of people should also be receiving boosters. As you know, actually, in fact, today, the booster Sisonke 2 has been operational in the health facilities and is being rolled out in the country. And the rationale for that recommendation for compulsory and a mandatory vaccination for health sciences students, for staff, and for boosters was, for number one, to save lives and to make sure that we also reduce morbidity. And secondly, to protect the health system, because we know that there's been an estimate that has been that about 40% or so of health workers actually have gotten COVID at this stage. So health workers are right in the front line, are the ones that are quite close to the virus, so to speak. So that was the rationale for that. And also from a teaching perspective, Glenda touched on the educational benefits. Also from a teaching perspective, with health sciences in particular, that yes, there is a place for hybrid learning online and face-to-face, but the practical kind of teaching, bedside teaching, is quite important if we are going to be able to prepare health workers that that will be fit for purpose and be prepared to actually work on the health platform. So that was the reason from the Committee of Medical Deans and Health Sciences Deans that came out with that in September. Since then, many of the universities actually have taken this even broader than health sciences students, and many of the universities have actually have started conversations within their institutions around the place of mandatory vaccinations within the higher institutions of learning. UCT, which is where I work, I'm at the University of Cape Town. What the process that we followed was that there was a motion that was presented within our Senate. The Senate is largely all the academics that meet. And at Senate, there was a motion that was presented, was debated. And as part of that debate, what was also reflected on some of the academic union had done a survey of their members. The SRC had also, who are also part of the Senate, had also done a survey of their constituency of the students. And from those surveys, there was a support for there to be a mandatory vaccination within the university. So then Senate, after the debate and exploring that motion that was presented, it was then agreed that it will be tabled at council, which is the highest decision-making of body of the university. But before it went to council, the executive, the VC and the management then set up further consultative processes where we had consultation processes for students and consultation processes for staff, where we shared information and staff and students had an opportunity to ask questions. And in those discussions also, a poll was done of people who attended. We actually had a huge support of those webinars that we had. I think for the staff one, we had over 1,500 people that attended. And from these two webinars, there's great interest. And as you rightly say, Ames, I think many people are grappling with this because at UCT, just these two webinars, we had over 1,000 questions that we are busy kind of collating and putting out into themes and preparing a Q&A that would answer many of those questions. After that was done, and when the executive was satisfied that they had reasonable support within the institution, it was then taken to council where it was further debated. And after that debate, council then had an in principle approval of mandatory vaccination at UCT and said that it's in principle. However, what they wanted was that they mandated the executive to set up a panel of a number of people who are from a wide range of disciplines that are relevant for this matter to actually grapple and come back to council in terms of recommending the logistics of how this would work, number one. And number two, to grapple with how exemptions would be implemented. I'm sure Halton is going to deal with the matter that there was a labor directive that gave guidance in terms of under what circumstances staff, in particular employees, could be exempted from receiving mandatory vaccinations, which is on constitutional grounds, on body integrity, religious grounds, etc., or on medical grounds. And so this panel would also advise on what are those grounds and how will they be dealt with? And in particular, what would happen if, for example, a student or a staff member chooses not to vaccinate? What are the implications of that? I think it's important for us to consider that we are living in South Africa with high rates of unemployment and access to education being an issue. So we have to be incredibly mindful when we set these mandates in terms of ensuring that we don't have unintended consequences as we are dealing with one thing. And as Glenda has articulated, there is absolutely public health rationale for us to be able to implement mandatory vaccinations. But certainly there is important considerations that we have to bear in mind and be mindful of in terms of consequences of that. And as that is currently what is happening where we are grappling with that. And many of the universities are at that same stage. And I think over the next few weeks, we will be seeing policies that will be coming from the different universities that are clarifying some of these issues and explaining how the logistics and the specifics of these mandates will work. Thank you, Ames.
Thank you so much, Tracey. That was really very, very informative. We'll move over to Halton now. And Halton, I'd like to ask you, how can you legally and ethically justify a vaccine mandate? And what are some of the laws that you actually used to fall back on? Halton, over to you. Halton, could you unmute, please?
Sorry, it's strange. It's a strange notion for me to be unmute. But
okay.
Let me begin by just saying that I want to contextualize my answer. My purpose is really to remove one of the arguments against mandates, namely the so-called violation of constitutional rights, in order for us to have a fuller debate and discussion on ethical, scientific, methodological, and political considerations of mandating COVID-19 vaccinations. The outline of my argument is that no right is absolute. In every constitution, not only the South African Constitution, fundamental rights can be limited by legislation if there's a compelling public purpose and the limitation is proportional. There are statutory common law rules that either require or permit the exclusion of unvaccinated persons from workplaces, premises, and vehicles that either do not infringe constitutional rights or justifiably limited. So let me also, by way of introduction, to point out that there are different ways of making a vaccine mandatory. There's a universal obligation carrying a criminal sentence or administrative fine. So in the United States of America, the state of Massachusetts in the early 20th century passed a law requiring all adult residents to be vaccinated against smallpox in the midst of a smallpox epidemic. This gave rise to a US Supreme Court case, in which it held that there was a public purpose, public health justified such a criminal sentence. So in other words, we're dealing with a public health law that requires everyone to be vaccinated. That was the basis of that particular case. Then you have what I would call specific mandates. Those are introduced by employers, universities, schools, airlines, sports stadiums, theaters, whatever. These kinds of mandates are the ones you see in New York, France, Italy, the UK, and elsewhere. These mandates are either authorized by specific laws, New York, France, and Italy, for example, or they're authorized by health and safety laws or property laws. So let me explain the difference. In France and New York, for example, they have passed laws that make it an offense for restaurants to allow customers to enter the restaurants without a proof of vaccination. Then there are laws that require employers to make the undertakings health healthy and safe, not only for their workers, but for all those who enter the workplace, such as customers and contractors. And then there's the common law right of owners and lessees of property to control who enters their property, reflected in that ubiquitous sign at the entry of most properties, admission reserved. And more recently, no mask, no entry. And this applies to airports, airlines, sports stadiums, theatres, restaurants, and the like. Now, let's just have a look at the question of constitutional rights are not absolute. Constitutions, in one way or another, permit legislatures to pass laws to limit constitutional rights for various reasons, such as public safety, the protection of public health, prevention of crime, and with different levels of intensity, some rights attract more compelling reasons. So the South African Constitution and the Canadian Charter of Rights and Freedoms have a general limitation clause written into their constitutions, which require an investigation into the importance of the purpose of the limitation and its proportionality. In other words, an inquiry into the extent of the infringement and whether there are less invasive means to achieve the same objective. In the seminal case dealing with mandatory smallpox vaccinations in the United States, the US Supreme Court in the early 20th century held that because smallpox was a real and immediate threat, it was permissible for the state of Massachusetts to exercise its legislative powers to promote public health and safety. And accordingly, an individual's rights had to yield to the state's powers to preserve public health. So no right is absolute. And now I need to. So if we now look at the laws that might infringe constitutional rights, the first set of laws are the occupational health and safety laws that apply to almost all workplaces other than mines and merchant shipping. So Section 8.1 and Section 9 of the Occupational Health and Safety Act imposes a duty on all employers to take reasonably practicable steps to ensure and maintain a safe working environment, not only for its employees, but also for any person who may be directly affected, such as customers and contractors. The same applies to mines under the Mine Health and Safety Act. Given the overwhelming evidence of the efficacy of COVID-19 vaccines and the fact that the government actively promotes vaccinations, though steps short of making it mandatory, there is little doubt that a court will hold that requiring a vaccination is a reasonably practicable measure as contemplated in those two acts. What is important in this just justifiable inquiry is whether the importance of the purpose of the limitation, here public health, outweighs the interests protected by the rights, bodily integrity, or religious beliefs, and if so, whether the limitation is the least restrictive means to achieve that purpose. Important too in such an inquiry by a court is what other open and democratic societies based on the values of human dignity, equality, and freedom do in similar circumstances. Well, we've heard from Glenda that that mandates are part of the United States, part of France, part of Italy, and elsewhere. And by the way, in any limitations analysis, what comparative authority and comparative legislation is very important in determining the proportionality or the justifiability of a limitation. So when we look at comparative inquiry, we see that the US courts have consistently held that an individual's rights have to yield to the government powers to preserve public health. There's the US case in relation to smallpox, which I've dealt with, which is Jacobson versus Massachusetts in 1905. There's the European Court of Human Rights in Wawrzyka versus Czech Republic in which various applicants challenged mandatory vaccination legislation under Article 8.1 of the Convention. But that article permitted legislation necessary in a democratic society to protect public health and others. The court upheld the legislation on the grounds that the object of the legislation was to protect the populations against diseases that posed a serious risk to health and safety. And very importantly, that the attainment of a high level of vaccination within the society at large was a means to do this. The constitutional courts in France and Italy have upheld vaccination mandates. So my conclusion is accordingly. It's legally not correct to say that constitutional rights will be infringed by a mandate. And even if they are infringed, they are justifiably limited. So let's engage in a robust discussion on whether mandates will be effective and what forms of mandate are more effective than others. And whether incentives and better communication of the benefits or risks of vaccination are a more prudent course, free of the misleading and grandstanding claims as to constitutional rights. Thank you.
Thank you so much, Halton. There are quite a few questions that have actually come up on the chat Q&A, on the Q&A, and some of them specific to you as well. But Glenda, I want to start off with you. I know you've been addressing them directly on the chat, but oftentimes we do get asked the question, and I think it's important for everyone to hear this from you. We do get asked the question that if vaccines are unable to protect us from actually getting the virus and also spreading the virus on, then why should we make this mandatory? So what is the science behind it all? Thanks. Over to you, Glenda.
Okay. So I think first and foremost, all vaccines are developed for individual benefit. So when we give a child a measles vaccine or we give a child a pneumococcal vaccine, is to protect that child from getting measles or pneumococcal. We do know that the COVID-19 vaccines downgrade infections from critical to moderate to severe to asymptomatic. And so we do know there is a correlation between viral load and transmission. And so that the most impactful of these vaccines impact on severe disease and critical disease, which protect your worker, but also they have been associated with decreased transmission. And so the first phase of the vaccine trials weren't designed to look at transmission. They were designed to look at individual benefit. So when we talk about vaccine mandates, we're not just talking about preventing transmission in the workplace, which vaccines will do, but we also talk about protecting our workforce. We don't want our workforce to die, and we don't want our workforce to go to hospital, and we don't want our workforce to transmit the virus in the workplace. And so it's a multifactorial benefit. And first and foremost is to protect the health of the worker. So I don't understand why people don't understand why vaccines don't benefit the individual. And if we want to protect people from dying, that's an important thing. And the secondary or other benefit is that it also may impact on transmission in the workplace, which we have seen evidence of. And there are trials that are running at the moment to demonstrate this as the primary hypothesis. But we have seen, as we look at the data at a global level, is that there is a relationship between vaccination and a reduction in transmission. So we can't ignore that. But for me, the most important thing is to protect the healthcare worker and the worker in the workplace, and to prevent death and dying of workers who are needed for their household. And so I think there are two benefits for vaccinating workers. One is to protect them, and the second one is to impact on transmission at the workplace, which there is evidence that is accumulating at a global level.
Thanks, Glenda. And just before you go off and I move on to Tracey, I just want to know, and this comes on the chat, that, there's a question of whether acquired immunity would count as protective. And would there be a need for a vaccine then, if there is already acquired immunity?
So
Thanks.
people who have get natural infection, their immunity does wane over time, and they're not immune to getting reinfection, which we've seen even in South Africa by following our healthcare workers that worked it in previous waves. And so prior infection, unfortunately, doesn't protect you against future infection because, one, your immunity wanes, and because with the various variants of concern circulating, you may be more susceptible. We have seen that vaccinating people who have had COVID before increases the durability and the maturation of the immune response. And so it's like having, I guess, a double dose vaccine, a prime and a boost. So if you have had a previous COVID infection, by being vaccinated, you're going to increase your immune response, and you're going to increase the diversification of your immune response, and you're going to increase your ability to cross-protect yourself. And so having a COVID infection is not going to protect you against future. And the risk of having COVID infection, you may die. So if you want to get natural infection, it might lead to death. And whereas having a vaccination certainly will not lead to you being directly affected through the COVID vaccination.
Thanks, Glenda. I'll give you a break while I move to Tracey. Tracey, I got some questions sent to me before the webinar, and this was from Moabi Malebi. And what he's asked is, given how poorly some USA colleges reopened in September, how will the institutions in South Africa be better prepared for come January next year? And specifically, he asks, what will the universities have in place as additional mitigation layers, that is in lecture theatres, classes, staff offices, staff communal areas, labs, residences, etc. And the second one is, what class to lecturer capacity can be expected once universities reopen? And what will the quarantine on-site or off-site and contact tracing policies look like? Quite challenging questions, Tracey, but I'm sure you will them.
So as I alluded to when earlier on, that many of us in the academic institutions are busy trying to grapple with those questions. So we don't have the answers. As I said, at UCT, we've set a panel that is going to grapple with some of those questions and make recommendations to council around how those will be managed. However, as we sit right now, and I think one of the things we've seen with COVID is that things move very fast, and policies also change very fast as we are responding to the pandemic. As we sit right now, some of those questions, for example, that you asked with regards to social distancing procedures, venue capacities, etc., we are guided by current legislation. So as things stand right now, the universities cannot have their own kind of rules and policies as it pertains that overrule what is currently in the legislation. For example, that people should be 1.5 meters apart, that there should be 50% venue capacity and things like that. These are some of the things that are still in legislation that we still need to adhere to. However, I think some universities have already written, for example, to higher health to request the implications. And I think that's what's happening now as we are grappling with this. We are all looking at what are some of those implications that would pertain to these mandates being operationalized. And I think it's quite important, and I think the rationale for us proposing this policy is very much from a public health perspective and from saving lives and from saving the economy. The intricacies, however, of implementing that are very much dependent on the context. Some of the challenges, for example, is that some of the universities take, for example, Stellenbosch University, that is completely integrated within Stellenbosch, the town. If you are going to have a vaccine mandate that says, for example, some people who are vaccinated can come onto the campus, how do you actually manage the entry and exit into that if the campus is so integrated? I'm saying these are some of the issues that we are having to grapple with, because context is always very important. Yeah.
Thanks. Thank you, Naledi. I'm going to move on to Halton now. And I'm going to ask Halton to explain to the delegates why you're actually drawing from international law and why you chose to use the 1905 smallpox vaccine decision as an example. There's a few queries on that. And then the second question to you is, could you expand on the limitations based on religious objections? How can you justify that? Because in certain jurisdictions, limitations are not enabled on religious grounds. Thanks. Over, Halton.
Okay. Firstly, if we look at our constitution and section 36 of our constitution, it provides specifically that a limitation must be justifiable, taking into account comparative jurisprudence and laws in democratic countries. So in the limitation clause itself, it's the benchmark is what comparative democratic jurisdictions decide, both legislatively and judicially. And then in section 39 of the Constitution, it says that a court must take into account international law and may take into account comparative law. So that's why one has reference to what constitutional courts do in the USA, France, Italy, India, Botswana, wherever. And one of the reasons why I chose the US example is because the Constitutional Court in 1905 was more conservative than the present Constitutional Court. And that's the US Constitutional Court. And it had no difficulty whatsoever in finding that the public health arguments for making smallpox vaccination mandatory amongst the adult population as constitutional. That decision in 1905 has been followed time and time and time again, both by the US Supreme Court and by all the appellate jurisdictions in the United States. And very recently, it refused to hear an appeal from the Indiana Supreme Court of Appeal on the grounds that the Indiana University had made the vaccination, COVID-19 vaccination, obligatory, and it refused to hear the appeal. And there's only one reason for why it's done that, is because the precedent has been set. So it was set in 1905, but it's still set now. So, and our Constitutional Court has reference then to other courts, and I mentioned briefly in my short introduction that both the French and the Italian constitutional courts have found vaccinations, mandatory vaccination requirements to be constitutional. And then I've also referred to the European Court of Human Rights in relation to vaccinations, mandatory vaccinations. So to just expand on the limitation clause analysis. So what is required in a limitation clause analysis is, first of all, to look at the nature of the right. And the nature of the right is a deeply personal right. We're dealing with now the right to religion, we're right to the control of one's own body. So these rights are deeply personal, and although there's no hierarchy of rights in our Constitution, what it means, the nature of rights means that you have to have a really good argument if you're going to infringe them or limit them. And then one looks at the second part of the things, to look at what is the purpose of the limitation, and how important is that purpose? Well, and I'll leave it to the scientists, to argue how efficacious the COVID-19 vaccines are. But it seems to me that the argument is so compelling that that the proportionality part of the discussion afterwards. So we first discuss how important it is, and then we look at the proportionality. Now, how invasive is this? And first of all, it's for free. Secondly, the directions indicate the directions under the National Disaster Management Act, provide that employers should provide transport and the like, and finally, what is the difference between a jab in the arm and a pill? So when we look at the infringement, it's really a very in one sense, I think the infringement isn't particularly compelling, and that's why I think when you engage in a proportionality analysis, if the Constitutional Court had to deal with this matter, it would seem to me that the Constitutional Court would have no difficulty whatsoever in making and in determining that it is constitutional.
Thanks, Halton. So in terms of employer mandates, and from a labor law perspective, should there be an injury, a mandatory, from having a vaccination, who's actually responsible in terms of compensation for that injury?
Well, there are two possible responses. The first of all, the government has set up, as a result of J&J's initial insistence that it should be given an immunity from any claims arising from adverse effects from vaccination. Interestingly enough, the European Court of Human Rights and the Italian constitutional courts have said that it's essential that if you're going to make vaccination mandatory, there must be some compensation for those who suffer adverse effects as a result of the vaccination. And the government has established a particular no-fault compensation fund for adverse for claims arising from adverse effects. But in any event, the Compensation for Occupational Injuries and Diseases Act, COIDA, also provides a compensation for individuals who, or workers who suffer adverse effects as a result of vaccination. So it's a really important part of the constitutional argument that that provision must be made for compensation for employees who suffer adverse effects from vaccination. But I'm going to leave it to Glenda to substantiate me on this. But as I understand it, we're talking about 1 to 2 per million in relation to adverse effects. When we look at our motor accidents and murders, we're in the region of 350 to 400 per million. So that's what we're dealing with.
Thanks, Halton.
Yeah, sure. These are rare events. We're talking between 3 and 4 per million vaccinated. So these events are rare, and the risk of COVID infection and their infection and their events are far more. So if if you compare thromboembolic events with COVID-19 infection and thromboembolic events with vaccines, there's no comparison. And so I think that's the important thing. One must look at what are the risks of the side effects of getting COVID versus the rare events that we see with COVID vaccination. Billions, I think we just need to go back. Billions of vaccines have been given at a global level, and there has been no safety signal that's caused these vaccines to be closed down at a global level. And South Africa is no different to the rest of the world.
Thanks. Thank you, Glenda. There's just one last one for Halton. And this is Halton. Can you please explain the legal processes involved should an employee refuse a jab? Could that individual be dismissed from work?
So the simple answer is yes. The more difficult answer for employers is the human resource complications and issues that raises. So what is quite interesting when one looks at how both the federal government in the United States, or the president has done under an executive order, and the New York City has dealt with in relation to its police force and health services, is that they have simply stated that no, you're not entitled to come to work unless you're vaccinated or can have proof of a negative test, and if you can't do that, then you don't get paid. So I think the first response of the employer is basically to do what the employer would do now of an employee who came into the workplace without a mask or with symptoms associated with COVID. You say, sorry, off you go. And although an employee with symptoms of COVID could argue that they're sick, then they're entitled to their sick pay. But we all know that there's a limit to how much sick pay you can claim. And if you've been sick in the last 2 years and you've used up all your sick pay leave, then you basically you unpaid. So the choice for the employee is either to get vaccinated or to pay for a test each week in order to prove that they're negative. And so that would be, so the result of that would be that there's no work, no pay. That would be the result of it. An employer who obviously required somebody like a driver or a critical employee would, after a certain period of time, have to retrench the employee or dismiss the employee on the grounds of incapacity. And that happens if you think about it. It's like this. I mean, an employee has a driver's license, drives for the company, and loses the driver's license because of an accident or a court case and the like. Well, the employee no longer is capable of working. They don't have the license. They don't have the vaccination certificate. They don't have what is required in order to be employed in that particular job. And on that basis, an employer can generally terminate on the grounds of incapacity. My advice to any employer is to terminate on the basis of operational requirements, but only to do that after exhausting every procedure possible to persuade the employee that it's in the interest both of that employee, that employee's family, and that employee's co-workers to be vaccinated. And if one looks at the Occupational Health and Safety Direction published by the Minister of Employment and Labour in relation to this, they set out a process that employers should follow. And it's a process about providing employees with information about vaccinations, advising them information about adverse effects, allowing them to speak to their unions and to their representatives, to counsel them before dealing requiring the mandate, and as long as an employer follows that process, I think the ultimate result is either no work, no pay for a period of time until the employer is required for operational requirements to employ an alternative employee.
Thanks, Halton. And there is a comment, and I'm going to take this one before we actually finish off. And that is a comment that states that there's been a lot about the legal aspects of mandates, but nothing in terms of ethical issues. And I just like to say that from my perspective, I think the law has been informed by ethics. And here we're looking at individual rights versus the common good. And so the law and ethics is very, very interlinked here. And if there's any separation, it's a false separation, actually. And I think we can draw from Ubuntu ethics as well, which looks at interrelatedness and interdependence. And, the famous quote, "I am because you are. And because you are, I am." So on that note, I would like to thank our presenters. I would like to thank you, our audience, for spending time with us. I'm about to get into load shedding. So unfortunately, we will have to close up now. It would have been great if we could have had our three speakers just give us some take-home messages, some quick take-home messages. And I'm just wondering, would you be able to do this in a few seconds each, please? And once you do that, we could then say goodbye. So I'll start off with Glenda.
I think it's really great. I think the questions raised, sorry, I ran out of time to answer all the questions, so I gave up in the end. But I think this is a wonderful platform to discuss these things, and I think a great way to have a dialogue. So thank you to everybody, and I think many more to come. Thanks, Ames.
Okay, sure. Tracey?
No, similarly, immense gratitude for this opportunity to have this conversation. And as I said, for me, we had over 1,000 questions. So what that tells me is that everybody is really keen to talk, to understand. And as we are grappling with mandatory vaccination, we must still push on in terms of sharing information, spreading the word, trying to convince people who are still hesitant. That doesn't stop. We continue with that until we kind of sort out the details of how we're going to do mandatory vaccination. Thank you very much to everybody that participated.
Thanks, Tracey. And it's all our responsibilities to actually build up vaccine confidence, not just the webinar tonight, but also in terms of all those that have actually attended the webinar as well. We do it for the health of our nation. Halton, a quick take-home message from you?
It's legal. It's constitutional.
Okay, thank you. So I just wanted to thank the audience. I'd like to thank the speakers, and I'd like to thank the Bioethics Advisory Panel for promoting this sort of activity, and also the people, the support staff at MRC that worked very hard at getting this webinar off the ground in a very short space of time, especially Patrick Charles, who has worked very hard in setting up the processes and ensuring that we all got heard and our messages will actually be disseminated, and he will get a link for all of us ready by tomorrow where we can view the entire webinar again. So thank you, Patrick. And with that, enjoy load shedding if you're going into it. Good night.
Good night.
Good night,
Thanks.
everyone. Bye-bye.
Thanks. Bye.